All right. After more than 20 years working in one of the busiest IVF clinics in the United Kingdom, Eleanor couldn't ignore the increasing need for honest conversations, clear information, and forward-facing approach to support people through what is a supremely challenging journey. The choices and decision-making needed, whatever stage you are at, have become so much more complex. Yet a Google search will send you in a million different directions. Finding someone who understands the science and is qualified to listen carefully to your individual needs has become invaluable to reduce anxiety and feel more in control. So, as that said, Eleanor is here with us today from the United Kingdom, and she is a clinical embryologist as well as fertility coach. And we're really excited to have her here today. Thank you, Eleanor.
Thank you so much for having me today, and I'm very excited to be here. So I'm keen to get started, but before I do, just a quick disclaimer. So yes, I am employed as a clinical embryologist at an IVF clinic in London. But just to say that all the opinions expressed today are my own personal opinions, and they shouldn't be considered as a substitute for medical advice or diagnosis or treatment. So always consult your doctor. I'm also an accredited coach, as Brian said, and I've set up and run a fertility coaching service to support patients before, during, or after their treatment. And you can find out more about how I practice fertility coaching on my website or on social media. But one of the things that I do before a coaching session is to establish the boundaries of the coaching and to make sure that we all know what to expect. So today we've got our first Embryology 101 session. So I'm going to be looking at just some of the basics of eggs and sperm. And I'll be showing you a bit about what we see in the lab, not just the things that you can look at in textbooks. I'll explain some of the tests that we use to measure egg and sperm quality, and talk about why we might want to consider freezing eggs or sperm for future use. So let's get started. So let's start right at the beginning. So what is the official terminology? What is a gamete in the dictionary? And we've got a mature male or female reproductive cell that's capable of uniting with a gamete of the opposite sex. Okay, so that's the official definition. And this is usually what we see in the textbooks that shows us a human sperm and egg. But really, what does a human sperm and egg actually look like? And here we go. This is what we're really looking at. So on the left, we've got our human egg. It's here in the middle. It's surrounded by two types of cells. The dark cells here are the corona cells, and then we've got these fluffy cumulus cells all around here. The egg itself is the largest cell that the human body produces, and it's 1/10 of a millimetre wide. And we're looking at it down here under the microscope at a ×20 magnification. So that's the egg just inside there. And on the right-hand side, we've got some sperm cells. The sperm cell is actually the smallest cell that the human body produces. And it's 20 times smaller than the human egg. So we can see the sperm head is just 5 micrometers wide there. So they really are very tiny compared to human eggs. So let's continue. Let's have a few facts about human eggs. So a female baby is born with all of the tiny immature egg follicles that she will ever have in her life. And she'll start off with 1 to 2 million of those tiny little egg follicles in her ovaries. And those numbers go down as she gets older. So at puberty, there are about 300,000 to 400,000 of those little egg follicles. And by the age of 30, it's down to about 70,000 follicles. And by 40, those numbers reduce again to 18,000 follicles. And it's interesting to think that in her whole lifetime, she will only ever naturally release about 100 of those eggs in ovulation. So it's really not that many. Let's move on to think about sperm. So here we've got all the different shapes and sizes of sperm, and there are many. So in contrast, sperm are continually produced in the testes in a cycle that takes about 3 months from beginning to end. And there are some reports that the quality of the sperm does deteriorate with age, but generally sperm production doesn't completely stop as it does with eggs. So sperm are continually being produced all the way through a male's life. In a normal ejaculate, there are millions of sperm, but the quality of sperm production is quite inefficient. And as you can see, on the left-hand side, we've got our normal sperm shape here. We've got an oval head, we've got a neck piece here, mid piece, and then a long tail. So ideally, that's what we're looking for. But we can see there are many variations to that theme. Different shapes of heads, 2 heads there, a broken neck, a cytoplasmic droplet still traveling down the tail there, no tail at all, that sperm isn't going very far, a broken tail, a short tail, and all of those variations. Double tail, no, the double tail does not mean that the sperm can travel twice as fast. That's also an abnormal sperm. Yes, so it's not surprising then that even in a normal sperm sample, there should be at least 4% of the sperm that have this normal appearance. So if you think about it, if you've got millions of sperm to start with, if only 4% of the sperm are normal, you're still talking about nearly 1 million normal shaped sperm there in the whole sample. So it's just a small fraction, but actually, if we've got normal numbers of sperm, that's still quite a lot of sperm with this normal shape and appearance. Okay, so let's move on to the basics of looking at the menstrual cycle. So in a natural cycle, there are normally 2 phases. We've got the follicular phase at the beginning, and then the luteal phase, the second half of the menstrual cycle. So this starts with menstruation on day 1, and hormones instruct a small group of those tiny follicles to start growing. And one follicle grows a little bit more than the other ones, becomes the dominant follicle. And then by about day 13 to 15, and this isn't very average cycle here, and obviously nobody is absolutely average, so there are variations on this theme. But on day 13 to 15, that follicle grows so much that it actually then ovulates and then should be caught by the fallopian tube. After that, the remains of that follicle develops into the corpus luteum, which then produces progesterone to support the lining of the womb if that egg needs it, if it does go on to fertilize and then implant into the womb. So in a very nerdy way, I was very excited to see at a conference that I attended in January this year And I realised as I saw it, it's the first time in more than 20 years of working in this field that I've actually seen in real time an egg ovulating out of its follicle in the ovary. So I don't know if you'll find it quite as exciting as I did, but I wanted to share it with you um, because this is what happens in real life.
Actually, so we never really worked with humans before. Everything was done in a mouse for a really long time. And then very recently we initiated collaboration with Jennifer Barton at the University of Arizona, who develops OCT probes, falloposcopes, fiber-based probes, which.
So I hope you could see that. Here is the follicle, the growing follicle on the ovary, and it's just like a little fluid-filled sac. And at that point of ovulation, the cells, remember the cumulus cells, started to just burst out of the top of that follicle there. And as they came out, then the egg followed. So I'll just show it one more time.
Actually, so we never really worked with humans before. Everything was done in a mouse for a really long time. And then very recently we initiated collaboration with Jennifer Barton at the University of Arizona, who develops OCT
that's the egg.
Probes, falloposcopes, fiber-based probes, which.
I think it's just brilliant.
Actually, so we never really worked.
I do too.
Thank you for your support there.
Just in case you felt like you were the only one, it's pretty incredible.
Thank you so much. Well, I think it is pretty cool to be able to see what actually happens inside your body. So yes, that's how things happen in real life. But what happens in IVF? So I thought we'd just go back to this average cycle again and just think about how this is different in an IVF cycle. So the hormones that the body would normally produce to stimulate the follicles inside the ovary, you actually take injections of that hormone. And so you will have that hormone in larger amounts, and it's called follicular stimulating hormone, FSH. And so as you take your injections, more than a small group of those follicles will start to be stimulated and start growing. And because there's more of that FSH hormone there, then more of the follicles will start developing, and more than just one will be able to grow and mature an egg inside it. So once you've taken those injections for usually about 9 days, then you will have a scan, and that will be to see how those follicles are developing on your ovaries, how your body is reacting to that FSH hormone. And it depends on the reserve in your ovaries as to how much of the FSH you might need to take to stimulate your ovaries. And this is why FSH can be used as a measure of ovarian reserve. So if you take a blood test measuring FSH, the higher the FSH is, the harder it is for your body to work to actually stimulate some follicles in your ovaries. So if you have a high FSH level, even on that first day of this menstrual cycle, that's indicating that your body is working really hard to be able to stimulate a follicle. So it indicates that there are less follicles available. Okay, so once you've got enough follicles there that are growing well, then you'll obviously have your egg collection planned. But rather than leaving the eggs to ovulate, then we will do the egg collection procedure just before that, so that we can actually collect the eggs into the laboratory rather than them being ovulated, just as we saw in the video there. So this is a really big question that we often talk about in coaching, and we're often asked in the lab as well. How do we know what the quality of the eggs is like? So I've already explained about how the egg is supposed to look. So initially it's surrounded by these tighter corona cells, and then a cloud of cumulus cells here. So we know what we're looking for initially, and sometimes we will then go on to remove those protective cells from the egg so that we can get a closer look at the egg itself. And once we look more closely, we can see whether or not that egg is mature or ready to accept a sperm. So, for instance, if we're going to be using ICSI, or an injection of the sperm directly into the eggs, we need to be able to see that egg a bit more closely so that we can tell whether it's ready to accept the sperm or not. So that's one way that we can know whether the egg has fully matured, but it still doesn't really tell us about the intrinsic quality of the eggs. And there are some AI developments in AI that I think will eventually be able to help us a bit more to determine what that intrinsic egg quality is like before we've tried to fertilize the eggs, or before we freeze the eggs, so that we have a better idea about what is the quality and what are the chances of that egg going on to fertilize when we come to do that. But currently, we don't know too much just from looking at the eggs. These days, many more clinics are using PGTA to have a look at the chromosomal quality of embryos. And so that is giving us a little bit more of an idea about the intrinsic quality of these eggs. And we've got enough data now to be able to understand in a bit more detail about what to expect from an egg, depending on the age of the woman that the eggs come from. So from the age of 30, we can consider approximately, and these are just average figures, approximately 3/4 of eggs will be chromosomally normal. So they'll have the correct complement of chromosomes there. But that does go down as you get older. So by 35, it might be down to about 70% of eggs that are chromosomally normal. By the time you get to 38, it's gone down to about 60%. And then at 40, it's about 35% of the eggs that we collect from a 40-year-old will be chromosomally normal. So as we can see, this between the ages of 35 and 40, there's quite a lot of movement and quite a big deterioration in the chromosomal quality of eggs. And so what that means is that eggs which are not chromosomally normal will be much less likely to be able to create embryos that will then be able to go on and implant and make a normal pregnancy. So that is giving us a little bit more of an insight into why IVF works less often as a woman gets older. And so this is one of our main problems, really, and one that we can't really change. And so this is one of the things that it's just out of our control. We can't change the quality of an egg, although what we try to do is, in coaching especially, is think about what are the things that might be in our control and that we might be able to do to help us to prepare the best raw materials, the best egg and the best sperm that we can, despite the knowledge that as we get older, there are changes in the egg quality that we can't do anything about. So move on to the next slide. Unfortunately for us scientists who like to just look at the research, look at the papers out there, and go to the evidence to base our recommendations and our advice, Unfortunately, there is very little strong evidence that can help us understand what are the things that are in our power to affect the quality of the eggs or the sperm, in fact. Despite this, many men and women do take nutritional supplements before they have an IVF cycle or during the time they're having an IVF cycle. And these are sorts of things that you can just buy in the shops, buy over the counter, without need for a prescription. We're taking all these supplements, but really there isn't a lot of evidence to help us know the amount of these supplements that we need to take and whether in fact they're doing us any good, and also, very importantly, whether they might actually be doing us harm. So in this review, Roger Hart very helpfully has gone through a number of different supplements that are quite commonly taken and just looked at what is the evidence? Is there anything that can really tell us that this is definitely something we should be doing, or something that is showing a trend that might improve outcomes when we're thinking about IVF. So he takes a number of supplements like DHEA, melatonin. Those have been suggested that they might help with women who have poor response to the FSH drugs. Myo-inositol, which is a supplement that has been recommended for women who have polycystic ovarian syndrome or PCOS. He also looked at resveratrol, and that is a supplement that has actually shown, although it might show some benefits in terms of embryo development, it seems to have the opposite effect to the endometrium. And so this is something that is really important to know, that although there might not be any evidence, any firm evidence to show that there's a benefit, we also need to keep in mind that some of these supplements, nobody seems to know what quantities of the supplements that we need to take, that we have to be very careful that we're not doing any harm. Overall, and I think this has been the advice for a number of years now, that he's suggesting that actually a Mediterranean diet is something that's quite simple, that you can do, and that does seem to have some beneficial effect in the evidence that's available, even though the evidence is very poor quality. My question really about that was, what do you mean by a Mediterranean diet? I think there could be various interpretations of that, but overall it's eating an increased amount of fresh fruit and vegetables, more whole grains, nuts, and reducing the amount of highly processed food that you have. So it's a traditional, I suppose, healthy diet, which is something that many people can easily adapt to. And although this is not something that we know for sure will improve outcomes, we know that even if you weren't doing IVF, this is something positive that you can do in your life, and hopefully will make you feel better, feel healthier. So it's something always to think about, these things that are in your power and your control, as well as the other obvious things like sleep and exercise, are the key things to think about, that are in your control to maximise your chances of success with IVF. So just a little bit about egg freezing. So we've talked about the quality of eggs decreasing as we get older. And this is something to be very aware of when thinking about egg freezing. So there's quite a lot of in the news in the UK at the moment, and it was again on the radio earlier on this morning, and people worried that women are being misled into freezing their eggs and being given false promises about what egg freezing can actually do. So I think the first thing to think about here really is that if you freeze some eggs for yourself, a frozen egg is not the same as a frozen embryo. A frozen embryo is not the same as a pregnancy. And a pregnancy is not the same as having a baby in your arms. So egg freezing is really a number of steps back from actually having that outcome that you want. And at each stage, as we move through the process of IVF, the numbers go down. So if we start off with 15 eggs, for instance, we might have the first stage, which is once we've frozen the eggs, we need to thaw the eggs. So not all of the eggs might survive the freezing and thawing process. So we might go down from 15 to 12. And then after that, we need to fertilize the eggs. So it could be with donor sperm or a partner sperm at that stage. So of the 12 eggs that we have surviving, we might have on average about 9 embryos. So as the embryos develop, then the quality of embryos does vary. And from 9 embryos on day 1, we might expect about 4 or 5 of those to be developing well by day 5 or 6. So already the numbers have gone down quite a lot. And of those 4 or 5, we might replace 1. We might be lucky to have an embryo to freeze for future use. And then the chances of achieving a pregnancy from a high quality blastocyst stage embryo on day 5 might be up to about 50%. So if we're freezing eggs, we need to understand that this is not the same as actually guaranteeing that we'll be able to have a live birth or have a baby at the end of that. So although egg freezing seemed to start off as a sort of insurance policy for women, I like to think of it more as being a lottery ticket. So it's giving you a chance, but unfortunately, you can't really know for sure whether you're going to get that outcome that you want at the end. And we can only know that when we actually thaw the eggs and go through the process of making the embryos and waiting to see if there's a pregnancy. So these are all things to consider when we're thinking about egg freezing. As well as that, there is often a charge to keep the eggs in the freezer. So once you've frozen your eggs, you might then be asked to pay an annual storage fee to keep the eggs in storage. And if you're freezing your eggs in your early 30s, then you might be thinking about keeping them, or you might want to be keeping them for up to 10 or 15 years. There are no limits on the amount of time now in the UK that you can keep those eggs in storage. So that's also something to factor in, as well as the cost of egg freezing, the cost of keeping those eggs in the freezer afterwards. And finally, the thought that actually we don't have a lot of data at the moment, but most eggs that are frozen are unused. So I suppose it depends on the circumstances, but many people freeze eggs and then don't actually go on to use them. So whilst you can see that it's something that's reassuring to have your eggs frozen as a reserve, it may be that you never use those eggs in the future. So it's definitely lots of things to weigh up, and it's definitely a very personal decision. So really important to get all of the facts about what the chances are for you at your age, if you freeze your eggs, to actually having the outcome that you want by the end. And that's a very personal discussion that I think you would always want to have with your doctor before you decide whether or not this is going to be for you. Or you might want to have that discussion with your fertility coach. So what do we actually see in the lab when we're freezing eggs? So the freezing process, we're freezing that one biggest cell of the human body. It's a very delicate cell, so it's a process that's very carefully timed. We use some different solutions to dehydrate the eggs, and then we place the eggs right on the very end of this vitrification device. So this is where we put the identification details, and right on the end of this plastic straw here is where we put the eggs in a very small drop of that media. So we just use a handheld pipette to carefully manipulate the eggs onto there, and then the eggs are stored in liquid nitrogen until you come to use them. So liquid nitrogen is at minus 196 degrees Celsius. So the eggs are completely frozen in time. They don't change once they're frozen, once they're cryopreserved. So it's up to you then how long you want to wait before you then use the eggs. So that's quite a lot about eggs now. Let's go back to sperm. And just to think about how we assess the sperm quality, and the main way that we can do that in the simplest way is a basic semen analysis. So there are three things that we're looking for here. Firstly, we want to know what is the sperm count, and this is one of the devices that we can use to give a value to that. So rather than counting all of those millions of sperm, we'd not have enough hours in the day to do that. Thankfully, we have these devices to help us. So this one on the right is a macula counting chamber, and inside here is a 10 by 10 grid, and the volume underneath this this glass cover slip is a set volume, so that we know that if we count how many sperm are in 10 of those squares on the 10 by 10 grid, that's going to give us a sperm count in terms of the number of sperm in millions per milliliter. So what we're looking for in a normal sperm count is anything over 15 millions sperm per milliliter. And an average volume of a sperm sample is about between 1 and 3 milliliters. So a small volume, but we're looking for at least 15 million sperm in each milliliter there. So that is the first thing we're looking at. And the second thing, just to bring that earlier slide to life, is the motility of the sperm. Sorry for the sound disturbance there, but we can see now that how those sperm are moving. Some of them are moving rapidly. We've got some that are just moving on the spot, they're not progressing, and then some of those sperm just not moving at all. So we want the number of sperm that are moving progressively to be at least 40%. So it's quite normal actually for the majority of sperm in a sample not to be moving forwards. And again, in a normal sample, if we've got millions of sperm, even if only 40% of them are moving, then we've got enough motile sperm there for some of them to be able to reach the egg and fertilize it. So that is sperm motility, and we can count 100 sperm to see what percentage of those sperm are moving progressively So that's how we can give a value to that. Finally, the most subjective assessment of the sperm is looking at morphology. So in some labs, they will create a stain slide. So that means that the sperm stop moving and we put a dye onto the sperm to see all these different shapes and sizes. Somebody there?
There's somebody at the door.
So, as I said before, we're looking for sperm that appear this normal shape here. And it's normal for only 4% of sperm to have that normal shape. Here's somebody talking. So this is a value that can differ between one operator and another within the same lab. It can change between two different labs. So it's quite difficult to interpret the meaning of that morphology value. And so this is the one that we least rely on to help us to understand what sort of treatment we should be recommending and what the actual quality of the sperm is like. It's the best that we've got at the moment, although there are now some other sperm function tests coming out that can help us a little bit more with this. So what other sperm tests do we have? So this this diagram is just showing us a pixie slide. So this is, we're able to test here whether a sperm is able to bind to a chemical called hyaluron. And if the sperm can bind to that, so we've got some drops in the slide where we've got that hyaluron there, and we can select sperm that are binding to this hyaluron and use that to inject into the eggs. These sperm are more likely to be mature, and there was a large randomized controlled trial that showed that although it's not in all cases, although success rates don't improve, we can reduce the number of miscarriages that we have after IVF treatment by selecting sperm using this special kind of dish. So we are making some progress to try to look at sperm quality in a bit more detail. And there's still a great need to find more tests where we've got reliable evidence that they're actually improving outcomes. There are some tests of sperm that we can do, such as DNA fragmentation, although it can't help us to actually select a sperm on the day of the treatment. So DNA fragmentation tests can be done and give us a result, although there's no real agreement on what the cutoff levels should be for normal and not normal. There's a lot of disagreement there. So it's not practically helping us in IVF at the moment, but hopefully these things are coming so that we can start to look in a bit more detail at the sperm as well. So finally, just looking at sperm freezing. So when we freeze sperm, we've got the option to freeze sperm in ampules. So we add a cryoprotectant solution to the sperm. That dehydrates the sperm cells. We can put the sperm into these ampules, or sometimes we use straws, and then they can be taken down to those very low temperatures and protected. So if the sperm are dehydrated, it helps to stop ice crystal formation, and that's something that we want to avoid because that will damage the membrane of the sperm cells. So we can take these ampules and store them in that liquid nitrogen, very low temperatures, and we might want to do that if we're preserving fertility. So if somebody is going to have some surgery or possibly chemotherapy, then we can freeze some sperm before that happens to preserve fertility. And so it's a very useful technique that we can use. And obviously there's for a bit of scale, that's our pen that we can use to put all of the details on the amps, the identity and labeling and barcodes, so that we can, when we go to take the sperm out of the freezer, we know exactly whose it is. So I think that's really all that I had to say about a sperm. We're just scratching the surface here. So there's a lot more that we could say, but I think just in this amount of time, it's just a very whistle-stop tour, just the 101 of how we look at sperm and how we can store sperm for use in the future. And finally, the next steps. So what happens once we put the sperm and the eggs together? And what you can see here is a normally fertilized egg. So the sperm here are stuck to the shell of the egg. These are the ones that didn't quite make it. And obviously one sperm has got inside the egg and fertilized it. So you can see there are 2 circles inside the egg. That's one from each partner. And that tells us that this egg has fertilized normally. So there's a whole other world of things that happen after that, and embryo development and quality of embryos that I think we will leave for another day. And perhaps that's what we will discuss in our embryology 102, 201, the next one. So I hope that you found something interesting here, and some things have been enlightening for you. And I would encourage you to ask any questions that you would like.
Eleanor, that was awesome. That was so informative and so well explained. Very much appreciate it. I was going to say, if anybody has any questions, feel free to pop on, or you're welcome to drop them in the chat too. Eleanor, I have a question. I am curious. So even though the research is saying that like certain supplements really don't help egg quality, how much has that been studied? Like for how long has that been studied? Do you know?
I mean, I think it's something that's been looked at a lot, but unfortunately the studies have always been quite small. Studies can't be compared to one another. So when you have another study, it's not been done in the same way. It hasn't been controlled very well. It's looking at different outcomes. It's not using the supplement in the same quantity. There's no consistency between them. So one study might say, oh yes, we found a significant result using this particular chemical supplement, but another one then finds the opposite result to that. So it means that we can't use these small studies to tell us really definitively whether there is any benefit or not. But it's very tempting when you've got a study, even if it is a small study, it's very tempting that if it does find something, everybody's looking for that silver bullet. And then there's that question in your mind that if you're not taking the supplement, you might be missing out. And in this climate, in the IVF world, then, you know, everybody is so vulnerable to these things. Everybody wants to feel that they're doing absolutely everything they can. And I think the danger really there is that there are some supplements that we know have the opposite effect, and they can actually they can damage your chances of success. So this is something that, you know, obviously we've just got to be so careful of, and ultimately we're trying to do good science here, and we want to make things better for people. So ultimately we need to coordinate our efforts, I think, in research and try to do some bigger studies, some better controlled studies that would then remove some of these question marks. And actually, I don't think there is a silver bullet. I think that's why the Mediterranean diet, I think, is like a change of mindset. It's a change of how you think about nutrition. And rather than focusing on one tiny extract of one part of a food, I think often foods work together to give their good effects. And so I don't think we can expect that just trying to extract one part of the food will then give us one specific result. It's part of a whole bigger picture and a whole different kind of diet and lifestyle that work together.
If you don't mind my jumping in, I think that's also one of the difficulties in research is that many people who are likely to take supplements might also be making other changes that could be enhancing the supplements, but that's not necessarily a variable that we research or can control for. So if you have person A taking the supplement but does nothing else, but person B is taking it and changes their sleep hygiene and improves their diet and other things, there could be a synergy there, and we just don't know any of those things. So I think it, like you say, it is a very, very hard way to try to interpret what's beneficial because you have to put it in context of that whole person.
Absolutely. It's not a controlled experiment. It's very difficult to do a controlled experiment on a human being.
Ethically, yeah. We have some questions in the chat, Eleanor. We have two. The first one is from Alexander, and he asks, is there any correlation between the rising levels of microplastic in the bloodstream and fluctuating fertility rates?
I mean, this is not something that I specifically know about. And I'm not sure about the research on that. So I would always go to see if I could find any papers that might tell me about that first. But obviously, you know, it follows. There's increasing amounts of evidence about toxins in our day-to-day life, products that we're using to wash our clothes, and our cleaning products that can have effects on our fertility. And I think that evidence is growing. So it would follow that this is something that we need to keep an eye on, and it's something that ideally we could try to remove from our lives, although I'm definitely not the expert on how we would do that. I don't know if you've got any comments that you wanted to make.
We did. The next question is, what is your opinion that some studies mention that AMH can be increased? Do you think that that's a myth?
I don't think it's a myth. I think there are clearly some things that are in our power to do to improve our health, our overall health. And whilst AMH is not an absolute, so if you have lower AMH, it does not say, that's not to say that you can't have a natural pregnancy, for instance. It's a measure overall of the reserves of your ovaries, but there's a range. and some people will naturally be at the lower end of that range. And so, yeah, I think those things that are in our control, we can try them. And if your fertility is a reflection of your overall health, if you make changes to your lifestyle and your overall health, then that might affect your AMH. But having changes in your AMH is not having a pregnancy. So the AMH itself won't necessarily change, but you might be changing other things in your body that then might help you to actually fall pregnant. Unfortunately, these are things that we can't always measure. And although we do have some tools like measuring AMH and measuring FSH, they don't always tell us the whole picture. So I would focus more on making good, positive changes to your life rather than looking at the figures and the statistics that are coming out from your blood tests and things like that. Obviously, they are important and they do have a place. Hopefully that answers the question a little bit.
Does anyone have any other questions? If not, Eleanor, this has been so awesome. And I don't know about everybody else, but I'm very much looking forward to Embryology 102 now. I think this was like a really awesome foundation, and I hope everybody got as much out of it as I did, because even as somebody as like a, long hauler IVF patient myself, who feels like she knows like armchair, I'm an armchair expert. I feel like at this point you were wonderful and I learned so much. So thank you.
Even if it's just one new thing, I'd be very happy.
Yes, lots of new things, not just one thing. Well, yeah, y'all make sure to go follow Eleanor on social media and on LinkedIn, and obviously check out her website. And I will send a follow-up email to everyone after this that has the information on how to reach out to her, her website information, and obviously a link to rewatch the video in playback.
And share it with other people.
Yes, please do that. And obviously, as soon as we have information about Embryology 102 ready to go, that date is going to be April 29th. So you can go ahead and mark your calendar for that. And yeah, we will see everybody soon. Thank you guys so much for attending. Great job, Eleanor.
Thank you so much for having me. I think I need to, it's getting dark here now. I need to start putting the lights on.
Yes, it does look like it got a little darker over there.
Thanks,
Awesome.
everybody, for attending, and see you the next time.
Yes, sounds good. Have a good day, everyone.
Bye for now.
Bye.